It's a pleasure to moderate this panel on health systems and TB in India. When we were discussing the issues involved in TB, I don't think we could have come up with a better panel than we have today to discuss this issue. I have with me Sandeep Ahuja from Apasha, who is a well-known face in TB. I have Dr. Sachdeva, who most of us who work in TB know very well. He is from the RNTCP. I have Dr. Nair from the WHO, a well-known TB specialist. Kerry McBroom from the Human Rights Law Network, an important voice in human rights and health. And Dr. Sharma, who you heard from earlier today, who has been treating TB patients for a very, very long time and has very important insights to share on TB in India. Because we have just an hour, right? We have just an hour. I'm going to very quickly introduce the topics and some of the issues that we would like to discuss today. But we don't have to limit ourselves to these issues. I think this panel should be as interactive as possible because we're really talking about multiple issues here. There is the question of the public system, a very large, and as Dr. Sharma earlier pointed out, a very good public system, but not without flaws, not without challenges. Then there is, of course, the question of the private sector, where there is enough documented evidence of overuse and incorrect usage of diagnostics and treatment. Finally, most importantly, I think the pathway to cure. I have just come back last week from TB patients advocate training, and it was horrifying to hear some of the stories. These were not people who were illiterate, as somebody earlier pointed out, or lacked resources. These were very often people from middle class, people like us, but the amount of challenges that they had to face to access appropriate diagnosis and accurate treatment, 2 years, 3 years, in some cases 4 years. And what is amazing, I'm just going to link to Anand's talk here, what is amazing was how few of them saw this as a violation of their rights. Most of them thought the fact that even after 3 years, they got the right treatment, whereas they should have got it the first time round, was an achievement. And they were expressing what was their solidarity with all of us, not realizing, of course, that this shouldn't have taken this long. All 3 of them were MDR TB patients. They had to give up their education. 2 of them had to give up education. And suffered a great deal. Luckily, their families were very supportive. But we keep hearing stories from the ground where families are not supportive. What does the patient do, the TB patient do in such a health system where the public system can be, accessing the public system can be a huge challenge, and the private sector is really set up to exploit you? There are also the question of the determinants or the tinderbox that surrounds TB, right? You go to Bombay and you go to Dharavi and you find one MDR patient and you find 100 basically, because they're all living on top of each other literally. It's inhuman living conditions, no access to clean water, sanitation, quality health assurance, quality health services. We keep talking about universal health assurance, but I don't know where we are with that because the current state of things doesn't really allow us in the health system to promise any of that to citizens. The other issue that I quickly want to touch on is the question of stockouts, of counseling, and of funding. Experiences across disease areas have showed that counseling becomes a critical and important role in not just motivating patients to continue treatment, but to continue to access treatment. But how do you motivate a patient? Dr. Sharma was pointing to this, and I think it's very important. When you lose a set of daily wages and you can't really access treatment because you know that you have a family of 3 waiting, and what motivates you then to access this treatment? Then the question of actually being turned away in the public health system. Anand was talking of HIV stockouts. I've written about it in newspapers. The question is that for a poor person in India, when the public health system shows you a stockout, where do you go? Because this health system, both the public and the private, is not really talking to the to the poorest, in the sense, patient. That having been said, there are thousands, in fact millions of stories that you will hear from the ground level where the public health system has delivered. So rather than be controversial or necessarily contradictory in this panel, I'm hoping, and these panelists are possibly some of the best known names in TB, can actually come looking at solutions more than problems. I think we're all familiar with the problems. The last two speakers laid them out very well for us. So I'm going to actually start with you, Sandeep. You've worked on the grassroots. You run a very well-known program. What do you think are some of the challenges that a poor patient in the public health system, and when I mean public, I think public and private, face, and how do you think Pasha is addressing some of those challenges? If you could tell us briefly.
Oh, that's a very large question. Challenges are limited. You've talked about them, Anand spoke about them. I'm going to limit myself to just one, which is access and medicines. I think I can proudly and successfully claim that we've solved both of these problems amongst a host of many others. And one more which I'll point out is weaning away patients from the private sector. You might find that surprising, but I think I can lay claim to it, and we are now discussing with a research organization to do a study whether that hunch that we have is correct or not. Why do I have that hunch? The detection rate in areas we serve, along with RNTCP, I must emphasize, Operation Asha does not work alone. It works as an extension of the government's TB program. We are the fingers extending into slums and villages. We are not independent. We only and exclusively use government labs and government physicians. So we are fingers extending into the communities. In areas where we and RNTCP work together, the detection rate is 74% of the prevalence. All India average is 51. So we are definitely weaning away patients even from the private sector. We are improving access. We are not allowing stockouts. How do we not allow stockouts? Well, I think the first principle you have to believe in is that government and NGOs are partners. We are not the opposite ends of the spectrum. Now, every CMO, every chief medical officer, or every district medical officer has certain powers to buy medicines. For DST-TB, where the medicines are quite inexpensive, that power is actually sufficient in most of the cases to take care of stockouts. Immediate purchases on a daily basis. I remember in Delhi, the power is 5,000 rupees per DTO per day. So 25 working days, it's 125,000 rupees, $2,000. That's a lot of money for DST drugs. And DTOs have done it. At times, they've needed prodding from our good friend, Dr. Sachdeva, and his other people in the Central TB division, but they have done it. So we've solved this problem. It's only in 0.1% of the cases where we need to buy medicines on our own. And there, we have authorized our program managers a certain kitty, something like 5,000 rupees, where they don't even need to go to his boss and get an approval. They can buy medicines on the spot from a local reputable chemist. So no patient has to go without an injection or without a medicine, be it pediatric, be it anything else. I think I wouldn't take, we've limited time, so I'll stop there.
No, that's a very useful and a very good point of view. I actually want to take that to you, Dr. Nair. Now, this is a good example, but we know there are countless bad examples. There is this question of evidence showing that anything between 50 to 70% of currently patients continue to first seek care in the private sector. This question of private sector and disease control seem to be linked together. Sandeep's, what Sandeep has pointed us to is a very effective way of addressing some of this. But how do you think, what are some of the solutions that lie, because we cannot really do disease control until we effectively engage this private sector, and how do we address this issue?
Okay. First of all, I think that, I don't believe in this distinction between TB patient and other patients. And also, I don't believe the distinction between government, means government hospitals or government system or RNTCP, and private sector. Because this is traditionally, we just thought that, the TB can be controlled by public sector program involving only public sector. And we also somehow still believe that TB patient means somebody who is being diagnosed with TB. But the fact is, the same people, those suffering people are outside who are not diagnosed. They don't have they are the people with the cough or fever or weight loss or some other symptom, and for them, it is not a TB. They go to a healthcare provider. They go to a healthcare provider who they have the confidence, who is more accessible to them. This we won't understand if you only look at Delhi or Mumbai or some of those urban areas where TB control program is entirely, so have got a vertical structure where TB clinics and TB dispensaries are available. But in the entire country, if you look at it, it is totally, the service delivery is totally integrated with the general health system. When I say general health system, it includes both public and private. And again, private is a spectrum. It's starting from the so-called non-qualified, number of non-qualified providers, you call them rural health practitioners or anybody at that particular level, to the super specialist on the other side with the 5-star hospitals. That is all a spectrum. Now, if 70 to 80% of that health-seeking behavior of the people is such that they will go to such centers and not to the government centers, how do you expect to have any impact without engaging them? So there is no doubt, if you are looking at tuberculosis control, we need to look at that health-seeking behavior of the patient who go with cough or fever and do that. Now, I see a lot of opportunities. The opportunities are because these people who approach these healthcare providers, they should be equipped to do the right diagnosis and the right treatment. We know traditionally, private doctors, in fact, once they come out of their graduation, they start practicing, it's very difficult to make any changes. Unless you are talking about something, the most of the lessons they learn it from some medical representative or other sort of agents who comes up, there is a new thing. However, in the program setup, there are trainings and capacity buildings continuously happen. So one of the main area is that they need to know about what is right, what is the standard of diagnosis, what is the standard of the right standard of the treatment, and what are their public health responsibilities. Someone who is managing tuberculosis need to take care of certain public health responsibilities. So this awareness generation and capacity building is extremely important for the private sector. And then we need to really use that, how we use their services, or for TB control, how do you use their services? Nothing comes free. Everything has got a cost. And we need to use that particular various strategies. And there is no real shortcut, there is only one way. The RNTCP program as such has been involved in a number of schemes. But I don't think that all of them has been so successful. So we need to continue to explore it. There are some very good recent examples where the private providers were sensitized and they were given these options for following the standard diagnosis and standard treatment without too much of impinging, disturbing guidelines. Systems for notification, etc. To do the public health responsibility, they were given systems like mobile applications or call center applications where they can use their notification. And we saw some very good encouraging results coming up earlier. So there is a long way to go, but I have got no doubt, I would always consider the private sector as a huge resource, No, but at the same time, I will also see that it's like a waterfall, the huge waterfall. If the power of that water is so much. If you can tap it rightly, you can generate electricity, and you can do all those things. But if that it comes out as a flood, and if it goes up, it can be too destructive. So that is where we need to make proper dams and use good generators and see that that particular water force is converted into good energy.
I really like your analogy about water and its force, and that it can be both destructive and can be harnessed. Dr. Sachdeva, let me turn to you here. We've discussed this many times, and I know that you're possibly one of those people who thinks the private sector has a very positive role to play. But there are systemic gaps within the RNTCP, and there are systemic, and there is the question of engaging the private sector, like Dr. Nair pointed to us. And there are good examples. Do you think the RNTCP is poised effectively to take this forward? And where do you see the next steps in disease control coming from the RNTCP?
So, Chapal, thanks for that question. But let me first admit it's a difficult one. The question is that, yes, as Srinivas said, private sector is huge. It's one. Number two, it's not homogeneous. It's very large, very heterogeneous. It is also partly regulated, partly unregulated. The spectrum ranges from totally organized, semi-organized to totally unorganized. So having said that, no single scheme of things can work for the entire private sector, so you have to have a basket of approaches. So that's one point. Having said that, program did get into engagement of private sector about 15 years ago, and they started with one basket of services, which was contracting out services, which you may call it in corporate jargon, inorganic growth, as you take over the services from your partners, NGOs, pay them for your services, and then expand your reach there. So that was one piece which the program attempted. But what historically, if I go back, analyze that piece has had its role, but it has not yielded great results. It has not really yielded great results in the sense that about 5% of notification comes from the private sector, compared to whatever. I'm not debating about the numerator and the denominator. If 70% is coming to the program, of that 5% comes from the private sector. And those were the schemes which actually looked at the unregulated private sector. They looked at individual private practitioners. They looked at small NGOs. They did not look at, because they were the contracting out mechanisms had a payment which ranged from few thousands to maximum of 4 to 5 lakhs a year. And I think Sandeep will agree with me, that's peanuts for any organization to show or demonstrate their work. So having realized that, the next step was program was to go for a organized and a semi-organized sector. That's where probably you will get major incremental gains, and that's where you can show initial impact also. And that's so one of the initiatives with the organized sectors was involvement of medical colleges. That is a huge success under the program. So that's akin to what we call as you grow yourself. So I compare that to organic growth. So there, if you see, out of 400 medical colleges now, about more than 200 are private medical colleges. They are all contributing into the program. And if I look, roughly 1 in 5 patient is coming from that mechanism. So that engagement with an organized sector paid huge dividend in one way. But we didn't look, at that point, we didn't look at the whole spectrum of the other organized sector. Now we have corporate hospitals, they are another organized sector. You have DNB institutions, though they are not medical colleges, but they are imparting education. They are imparting higher level education to medical graduates. And they also have a good number of patients which are serving to them. Other organized sector within the public sector is your district hospitals, your other ministries, Ministry of Defense, Railways, employees, State Insurance Corporation. So then we started engaging with these organizations, and this has also led to some limited success. So now I see more of a role of engaging with these so-called organized sector. Then coming down to the semi-organized sectors is nursing homes and smaller 10 to 50 bedded hospitals. So that's where we can make some impact. So these are the plans where we can show hope, and that's what we need to do individually. Now to get at the unregulated private sector, the individual private sector, again with what the lesson from the past is that transaction costs are too high. There is one DTO in a district, some of them are here. If that one DTO has to engage with, say, 1,000 practitioners, he doesn't have the bandwidth to engage with 1,000 practitioners. Take the reporting from them, take feedback, monitor them. I don't think it's humanly possible for any person to do that. Again, then you have to put in some mechanism, some institutional framework there. And that's what the program is currently done in few districts. The famous example is the Mumbai TB control mission. Again, it has shown huge incremental gains. The mechanism was involving an interface agencies. So that is a public-private interface agency. The same experiment is being replicated in 2 other districts in Patna, Mehsana. So that's another mechanism which will work out, it will work out. But there may be many other mechanisms, there may be many other innovations which we have to look at. And holistically, I must say the program is open. We are very much open to engage with the private sector with the caveat that we would resist increasing transaction costs for our officials. Let there be some institutional mechanism developed for that, and so that institutional mechanism deals with the unregulated sector per se. The program can deal with the more organized sector to get more incremental gains. I don't know, have I missed any point?
No. I actually wanted to take your point to Kerry. Kerry, I want to ask you, you did a lot of work at the grassroots in understanding some of the challenges. We've been discussing the private sector up till now. I really want to turn the lens a little bit to the public sector because, Dr. Sharma very rightly earlier when he was giving the address pointed that we try, but there are so many challenges in the system. What were your findings of these challenges in the system? If you could throw some light on that, that would be helpful.
Good afternoon, everyone. I feel very humbled to be on this panel with everyone. I think maybe the only thing we have in common is that we all wear specs. Because my introduction into TB is fairly recent. I actually work in reproductive rights as my primary field of legal advocacy. And the way we got interested into TB is we found that so many of our clients who were dying as a result of inadequate maternal health care, as a result of inadequate antenatal care, many of our clients suffered from TB. Many of the communities that we work in, there's one community that we work in where every single family has at least one person who suffers from TB. Many families have had deaths even in the 2 years that we've been working with this community, and none of them are getting treatment for their tuberculosis. That's in Pool Matai near Old Delhi railway station. So we started, as a part of advocating for our clients, in addition just to looking at their reproductive rights, we decided to expand our work and our research on the ground to look at how these people's tuberculosis is getting treated and addressed. And the way we approach this from a human rights approach is we look at what the government is supposed to do under the Constitution, under international law, and under different schemes. And that means we look at the schemes on TB, but we also look at other schemes that address things like malnutrition, that address things like access to health care, that address things like access to, money for girl children, anything that's going to be a part of a family's well-being We look at the government obligations and we see what the government isn't doing. And that also means that we eventually hold the government accountable for failures to do what it's supposed to do. And I know anytime the term accountability is mentioned, my dear friends and people who I admire in the medical fraternity get very nervous, get very defensive. People who work in the government get very nervous and get very defensive because accountability is a scary thing. But when you have thousands of people dying every year from a treatable illness, when you have thousands of people who cannot access treatment, someone has to answer for that and someone has to be accountable for that. We view health rights the same way you would view a domestic violence case, the same way you would view someone being denied their right to vote. When that happens, you take action and you hold the perpetrator accountable until you get justice and the situation is ameliorated. So we did a fact-finding in 2012 and 2014 in different DOT centers in Delhi. And we visited almost 20 DOT centers. It was very difficult to do this because the contact information on the website is often inaccurate. Our office is in Bogal and Jungpura. We couldn't locate the address for the center in Bogal and Jungpura is not on the website. It just says Bogal. We had difficulty locating the facility in our own locality. When we got to the DOT centers, a lot of people were very defensive and secretive, and there wasn't a lot of transparency. But we were still able to have very good conversations at 20 DOT centers to observe the way that patients are treated, to observe the way that the center is set up, the way it looks, the conditions. And we found that across the board, there are rampant violations of the RNTCP guidelines, of basic patient care, of cleanliness and of hygiene. Sinks are universally covered in grime and dirt. One of the most shocking findings was that of the 20 centers, only 2 of them had drinking water. How are you supposed to take your medicine in front of someone if you can't fill up a cup with water and drink it? We found across the board, a lot of the providers themselves, and I don't think this is something that we've talked about so much, a lot of the providers also have very serious grievances. Some of them haven't received payment in 2 or 3 months. A lot of them don't have the human resources at their facility to actually get out into the field and do the active follow-up. Another big problem we have is that, or the providers mentioned, was that they don't have any means of protecting themselves. And if they get infected, they can't report that to their seniors because they feel that they'll be fired or they feel that they'll be punished in some way. And people at DOT centers told us that they knew providers personally who had died. Someone said that at least 100 DOTS providers had been infected and that at least 6 or 7 people had died as a result of not being able to report this, not being able to get treatment, and not being able to protect themselves at the facilities. And that was something that came out time and time again. Across the board, you just saw myriad problems in implementation, the way patients were treated. We're going to be developing a Delhi High Court case on this. The petitioner in that case is about 60 years old. Actually, one of the cases that Anand Grover put in his slide is the case of her daughter who delivered a baby outside of a public facility in Jungpura. She delivered it under a tree, but because she was on the property of the facility, they counted that as an institutional delivery. Now, her mother has multi-drug resistant tuberculosis. She was diagnosed in 2009. She did register at a center, but she never had any counseling. The nature of her disease was not explained to her, and she defaulted on her treatment. Now she has MDR. Her now 4-year-old grandchild, the girl who was born under the tree, has lived in, when they have money, a 1-room house. She never received treatment from the DOT center, as you're supposed to if you have an infected person in your house. Her daughter, Fatima, who delivered under the tree, has never received any treatment. And now she weighs probably 25 kg and is just wasting away in their house in the Nizamuddin Basti. And these are stories that we encounter every week in our work. And so we're working to hold the government accountable. We've already sent parts of our fact-finding to the government because some change needs to happen immediately. And it's not necessarily an adversarial process. I'm clearly very passionate about it and very angry about it, but doctors are not our enemy. The government is not our enemy. We want the government to do what it's promised to do. We're not asking for anything more. We're not asking for people to be punished or to go to jail. We're just asking for those very minimum entitlements that are guaranteed under the Constitution, under international law, Supreme Court judgments, and the government's own programs to be implemented in a way that saves people's lives. So if you have any other questions, feel free to ask.
And I just want to take this, actually, this is very interesting because we've been debating human rights for now the second day. And I think this is a very interesting and well put together, honest panel, because I think everybody here is admitting that there are challenges. The question, of course, that I want to take to Dr. Sharma is that, I'm sorry, sir, I wanted to come to you last because you're possibly the senior most on this panel in terms of dealing with patients. What Kerry is describing here are stories. And then, of course, there are stories of people accessing the public health system effectively, which something that Sandeep was introducing us to earlier. Now, how can we move away from the stories that Kerry is describing to the stories that Sandeep told us about, and also what, according to you, then become the biggest challenges in achieving this? Both, I mean, for a moment, I want to put aside this public and private sector divide and just focus. If a person has TB, it shouldn't matter where they go. And if it shouldn't matter, what do you think are the biggest challenges to achieving appropriate diagnosis, treatment? You alluded to determinants of health also in your slides, showed us very scary pictures. And if you could relate all of that, sir.
Thank you very much. I think time and again we are hitting the punchline. Actually, I am a fundamentalist basically. I always touch fundamentals. I will start actually where Anand, actually I wanted to ask question there also. My personal belief, actually I may be excused for that, you cannot compare two diseases. He tried to compare HIV, AIDS with the TB. Fundamentally that is wrong. I also gave example, probably he was not there that time, polio cannot be compared with tuberculosis. I actually told that in polio you can boil water. If water can be boiled, here air cannot be autoclaved or boiled. That is the whole issue. If you are able to do, if scientifically, you tell me then actually, that is one. He deliberately, the moderator deliberately said, don't touch the issue of public and private. I think that is the fundamental. I am not treating tuberculosis. I told you the story that in early 80s when I joined this institute in 79. So I will not name the person. When I was chief resident, so I admitted one. I was looking after one patient with cavity. So I was called by my head. He said, "Why are you looking after a patient with the sputum positive case?" He happened to be employee health worker. Actually, he worked actually in the hospital. He said, actually, our mandate is not to treat these patients. So he has to be referred to private hospital, this government hospital where they have the admission facility. But what we say actually that I used to look after that patient. Because I also realized the importance of transmission. So I used to treat him, give him medicines, and he was on my follow-up. I didn't send him anywhere. The only thing I gave him this thing, treatment, and he used to access the treatment from the hospital free of cost. Then came actually in my mind also the issue, he has family also. He was a chronic alcoholic also. These are the comorbidities or multimorbidities in these conditions. So actually I was all the time worried about his kids and other things who were actually in a small family. I know actually he used to live in the campus. Small family, no ventilation, nothing. He was alcoholic, smoker, whatever actually problems a human being can have. He had all risk factors for transmission and not to be cured. That is one issue actually also. When we are discussing about tuberculosis, I think multimorbidity, comorbidities, mode of transmission, then besides financing actually. Just yesterday I want to share this thing. The day before, yesterday my wife told that someone in the institute, she wants to, they want to have my opinion. This is a hospital. So she showed me a report. Actually, then I told that once upon a time this person helped me some way. So I actually, in the evening, in the night I told her that in the morning I would like to have, first of all, I do any work, I would like to see the report. Because that person helped me once upon a time. So I was scared actually. This was simple pneumonia. I'm not criticizing private. Actually, I need excuse for that. Simple case of pneumonia, community-acquired pneumonia, and being treated with anti-TB drugs. 5 drugs. We always say quinolone not to be given. So, and he had liver injury. Severe. Then actually I called the patient. I said actually I am sitting in the chest clinic yesterday. Send the patient. I want to have one-to-one interaction. So all sort of cocktail was given. Now the question comes actually, who are these public providers also, as Dr. Sachdev also mentioned actually. In our country, you cannot define private care provider. Even a chemist who sells the medicine, he is also. And let me inform you that we have been fighting. I have been at least fighting that there should be, for rational drug use, there should be legislation, which actually, when Grover was there, I wanted to touch that. That when he's talking about so many fundamental issues, legal related, I wanted to raise that also. Why are you not filing public interest litigation? I tell you my own story. When I used to work actually for workers, there used to be stone crushing industries in Lal Kuan area. In mid-80s, I used to go to teach students in the primary health center, which we have actually our Ballabgarh. Well, on the way, I used to see haze. So I was interested in working there since lung is actually my business. All these patients I studied, and I wanted to visit the quarry also, the quarries which were actually crushing the stones. I got choked actually after walking few of this thing. Then we did some, because I am in a tertiary care hospital with state-of-the-art facility, then actually we did very landmark studies and it got published, top chest journal now, American Journal of Respiratory and Critical Care. So it got published in that. Because of that, someone picked up that abstract and published in Hindi newspaper. And someone filed PIL. You will not believe, I am not exaggerating. In the middle of night, I used to get threatening calls. Because Supreme Court gave a judgment, actually was this case public interest litigation. So they said actually you have to move your queries to the, you may be knowing now, they are moved to the hillside. So I used to get threatening calls. I am not basically activist. But this is how my paper was actually quoted somewhere in the newspaper, and this was a news item, then this thing. Then these queries were shut down also. And some of the owners, they became jobless. Although they shifted also. What I want to say, the scene, horrible scene I saw, because that is it produces a disease, silicosis. Silicotuberculosis goes hand in hand. If you have 100 patients, ultimately they will die. And I saw a young person dying with tuberculosis, etc., all complication. Though I am talking about the 80s, and this paper got in, you can verify, actually I am the first author, and the impact factor of that journal is, I think, 13 or 12.5. And it is a highly cited paper also. So I am the first author. So I am telling actually story that there are several factors also. These people should be listening actually that what we are talking. We should not, first thing I told, just to recapitulate, you should not be comparing two diseases. You are talking about TB, it's not a new thing. Anujam actually Srinivasan actually who discovered zero, he died, he was in UK that time, at the age of, I think, he was, till now actually his theories of mathematics are to be decoded. He has written one diary, there was an international conference in Hyderabad, he died of tuberculosis. Those, whatever he has scribbled cannot be decoded. It is so advanced actually he has written, it was like Einstein actually. So what I am trying, John Keats, actually everyone may be knowing actually, the very famous poet, he died of tuberculosis. I am talking about that era actually. So this is a disease, I said in the morning also, multi-pronged attack actually. When actually he was saying, I was just provoking him also, that you are talking about counseling. I think it's you should get a 0 mark actually if you are answering my question paper. Counseling is not the answer. Why don't you get it introduced in high school, primary school? In the curriculum, how to spit. 80% of the people you are walking the mark, they will spit on you. How do you know he is not a TB patient? I am not discriminating here. But we do not have manners actually. Now no one, father is working, mother is working, no one has time to spend with the kids. They are not raised like that. These are the you are talking about the sanitation, air pollution, overcrowding, illiteracy. I think these are the fundamental issues besides the drug. Drugs actually is, I think everything is being put on drugs, vaccines.
What you're saying, sir, to Sandeep. Sandeep, you work very closely with the community. The question of human rights and the question of counseling and the question of motivation to continue this treatment, the toxic treatment, it's not easy. A lot of these folks are daily wagers. It's not easy. Looking at your experiences with Apasha, but also looking at a broader understanding of the health issues and the nutritional issues that surround a lot of people who access public programs. What do you think, very briefly if you could touch upon it, because we are mostly running out of time, touch upon the issue of counseling, the issue of community empowerment, and nutritional and economic support if we look at it. Because we know that a lot of these issues play a pivotal role in both treatment and accessing treatment.
I will begin by widening the discussion. First, as Anand Grover said earlier, governments are tied to paperwork. I actually worked for the government for 12 years. So I think, along with Dr. Sachdeva, I'm one of the few people who've been in the government. And bureaucracy by design is meant to implement laws, regulations, conventions, and precedents. Governments are not designed for last mile delivery. Last mile delivery has to go out of the government. That is the bigger issue, not just for tuberculosis, but practically for every disease. Why is that necessary? Because it's not just about counseling, and it's not just about patients' rights or informed consent. It's about making the patient the center of focus. Unless you can develop a patient-focused methodology, a patient-focused paradigm, you will not move away from TB. Your prevalence will keep going up, your detection will keep going down.
Do we have, or are we moving towards that paradigm? I mean, I know because you work with the RNTCP and...
No, we're not. I'm sorry to say we're not. Some of the elements that we use, so I was telling Lauren, we have a system whereby our auditors go around on a regular basis and talk to patients, and the questions they have to ask patients is, are you being treated respectfully? Were you provided first counseling session before your first dose was given? Are you facing any shortages of drugs? When you miss a dose, does someone ring you up? Or does someone visit your house and find out? When you have side effects, does someone advise you what to do? When you don't have food to eat, and that is not an exceptional situation. 10% of our patients are at any time on food rations from our donors. Why did you miss the dose? And there are patients who tell you, I've not eaten for the last 2 days. If I take the dose, I'll vomit. Fact. True. Unless you go back and say, all right. Again, our program managers are entitled to put patients on food rations without any approval. Without any approval from any higher authority. And so long as the patient is on treatment, the food rations shall continue. Women might be thrown out by families. We provide vocational training and tell the family, hey, look, this woman is going to get treated and become an earning member of your family. Don't throw her out. Because if she's thrown out, what happens? She dies on the street. These are truths. What happens to a woman who has no earning and who is abandoned by the family? We tell the family, we're going to train her, give her vocational training. We pay for computer typing if the woman is literate. We pay for learning embroidery and stitching if she's illiterate. If the family still doesn't agree, we also give food rations to the family. The whole focus is a patient-focused approach. And I must say, all this is done not by me. I only talk. It is done by my frontline workers, many of whom have been to school for a few years. Some have never been to school. How do I ensure even they deliver high-quality care? We have developed a biometric system in which patients can even be identified with pictures. So when a new patient comes, he's registered on the system throws up a dozen pictures, and the patient puts his finger on umbrella. He's umbrella forever in the future. He gets a small card which has the picture of umbrella pasted on it. Every time he comes, he's the umbrella. And the second thing, of course, you might say, I don't trust my staff. Well, yes, in certain ways, as a manager, I do not trust anyone, not even myself. The auditors I talked about, who go and meet the patients, do not report to my program managers, they report to my COO. So no program manager along the line, along the hierarchy, can influence them. So the basic thing, no warning, and the annual increment will not be given. You repeat it second time, the most minor thing, you will be terminated on the telephone. And the letter will follow later. So ultimately, it's there. Patient focus and extremely stiff, stringent MIS. You do two things, you can deliver any public health and go beyond.
Okay. I'm actually, I thought we had 15. No? We have 15. Okay. Because I want to spend the last 7-8 minutes opening it up to the audience and getting to discussions. But I quickly want to give the other three panelists a minute each if they want to comment. Dr. Sajiva, I was wondering on this question of nutrition and this question of rights, how are we going to resolve this? I know the program has been thinking, I'm sorry, I have a terrible cold. I know the program has been talking about this, but how is it going to take place? And where are we going to take this?
Chapal, before coming to nutrition, with your permission, can I respond to some of the other queries and give an overall program perspective? Because I think I'll be failing in my duty on being here in this panel and not responding the program perspective about things. Many of the queries concern what Sandeep said. I'll shape my response into, I just noted it down also. One is that accept the shortcomings. Whatever is this program must accept, because that's the only way to improve. Other is be defensive. Yes, partly this scenario is not as gloomy as sometimes it is made out to be in all these meetings, because we are focused on a problem. We generally try to focus on difficulties and other problems. We lose the big picture of it, that a lot has been done, a lot has been achieved. Even with bad systems, everything, we have achieved quite a lot, and we get about 1.5 million patients on treatment every year, of which 90% of them are successfully treated. So that must be placed on record. And I mean, one should not go on with a message that nothing is being done under the program. The other role which I assigned to myself is show hope. Yes, with all these shortcomings, we are progressing. We will keep on improving ourselves, and we will address the concerns as the program evolves and matures, and we have that much of confidence within ourselves that we can deliver the next mile now. Programs also evolve. When they start, they deliver a little. We started with just basic dots. Then we added TB, HIV. Then we added drug resistance. Then we are now adding monopoly. I mean, there is a evolutionary curve with all organizations, all individuals, and that's how that's the human cycle, how we grow from childhood to senescence. So that's is there with all programs, and as we evolve, we keep on addressing more and more things. Other is to the concerns that program must demonstrate action when something goes wrong. There is some grievance that we have taken an effective remedial steps to address those concerns. And then again, one should go back to the history, how the program has responded to those concerns. The newest one was about the drug shortages about 2 years back. A lot of press coverage, everything. But then, yes, program did respond to that, and now the things are back on track. So you have to demonstrate the problem of drug resistance was not being addressed 5 years earlier. Now you see you have so many laboratories on ground that we don't have now 100% utilization of those services as of now. I only get 40 to 50% utilization of those services because I don't get people are not referring them patients to me to be tested there. So this is also one stage in evolution. So we are doing something. The last thing is seek help. Okay, and that's what we keep doing. Everything, whatever we cannot do, we ask you, others, academicians, some people like Sandeep, experts like Dr. Sharma, and other institutions. Let's come forward, help the program to achieve the goal, because the goal is a national goal. It's not my program, it's not Sandeep's program, it is not Dr. Sharma's program. We are all concerned with TB patients per se, so we seek help, and that's how we shape up. What happens is that, let me also congratulate the fora here for bringing up so many issues. But again, let me clarify that advocacy is actually more about stories to highlight the issues. And these stories are not too many in numbers, but the impression which gets carried is that everything is wrong. Again, please don't get the message that everything is not wrong somewhere. And the other is how the programs get managed. Actually, there's a management principle which is called management by heuristics. You do most of the time it's common sense management, and whatever is actually doable is done. An ideal situation may demand a lot of things, but I don't think any country, any program, any organization, even an entrepreneur does an ideal thing. They all do heuristics. So the program also do heuristics management, and that's the science of it actually. So that's what I wanted to clarify to everybody. Now I'll come to your question on nutrition. Having said that, yes, we support nutrition fully. We realized, yes, there is an evidence which shows that, yes, if you are malnourished, your immunity levels are low, and then you are at high risk of contracting TB infection and subsequently that getting converted into TB disease. Having said that, the program also then, when we do an insight into it, I mean, I look inside me, what is my capacity to deliver? I said, no, I talked of an evolutionary curve. In the stage of maturity where I am, or when I say I am, where the program is, it's not me. Where the program is, does the program has capacity to deliver that? My intentions are to do that. Policy statements are statements of intention. I want everybody to get good nutrition. And now, what do I do if I do not have capacity? I seek help. Okay, no, I seek help from Department of Women and Child Development. I seek help from state government. I seek help from non-governmental organization. I seek help from entrepreneurs. I seek help from corporates. Okay, please come forward and offer these things to the patients and the community so that these are the externalities which must be addressed to. From program side, yes, we have demonstrated in pilot projects that nutrition, counseling, social support helps improve the outcomes. At this stage of maturity, we may not be able to expand them nationally through the mode of service delivery by revised national TB control program, but they can be expanded nationally through the mode of Department of Women and Child Development, ICDS, World Food Program, and we fully support and are ready to collaborate and on that issue. So that's the clear stand of the program on that issue. Thank you.
I want to turn to you very briefly because now we're completely out of time, but I want both of you to comment on some parts. Dr. Srinivas, Dr. Sachdeva just painted a compelling picture about what you need to do as common sense management on a daily basis, which the RNTCP is confronted with, and these multiple issues which we recognize as important, but we're not in at a point to scale up. Is this a question of funding? Is this a question of capacity? Is this a question of us just not recognizing that this disease needs this push? And I don't mean, when I say us, I don't mean any particular, I don't mean the government, I mean all of us.
Yeah, I think that there is a major issue with our way we look at the tuberculosis control. We traditionally had certain global policies which translated into regional policies, which is practically copied at national policies, and then we just expect that do this and that. Prescriptive way of doing certain things are going to solve it. Luckily, the tide is changing. People realize finally that, sorry, the TB situation is not the same in everywhere. Even the TB epidemiology is different in different part of our own country. The social situation is different in different country. The needs are different. So it is not just about the diagnosis and treatment. There is much beyond that need to be happened. So the solutions to most of our problems does not lay at Central TB Division or in the Dr. Sachdeva or his team. The solution remains at the local self-government side. So India, health is primarily, a state subject, and it is nowadays much more. It's a local self-government subject. We have excellent examples of taking it from the nutrition. There are many of the Jilla Panchayats have started certain nutritional supplementation or nutritional rehabilitation, nutrition additional social welfare schemes to TB patients specifically. And I just come to my mind an interesting program in Kasaragod districts and northern districts in Kerala, where all MDR TB patients were provided with a package of food materials. And it is not just for the patient, that is the beauty of it. It is for that family for 1 month. Okay, those who cannot afford it. The important thing is that you don't feed just to the patient, it is to the family need to be supported. And then it has been done with that. What is the TB program has done? They just highlighted that the issue at the local government and they found a solution. So I think that as an advocacy group, we have got tremendous role to highlight these areas, and you can have national policies if those policies does not convert into implementable solutions at the field level. This will just remain in the paper. We have got excellent policy. I think that this is one of my most passionate subject is on TB notification. We tried our level best, and a fantastic executive order has come for TB notification. But suddenly we all felt, activists, we had a lot of discussion with Blessy, and, notification is something which is, it's bad for the patients. And I will again tell you one simple story, last minute, 1 minute. My daughter, last week, 2 weeks back, she was admitted in one of the private big hospital just before I had to travel for a conference. She developed severe respiratory infection, asthma, she couldn't breathe. I took her to the next hospital. I have Dr. Sharma and AIMS or many LRS hospital and a lot of government hospitals are, I have got very good access, okay? But at that time, personally, my confidence is to take my child to that next hospital who has got all those facilities. They did a series of investigation for those 2-3 days, and finally they found that dengue fever, one particular test positive, okay, and other 2 tests negative. And when I came back, I got a call when I was in Goa in a meeting. I got a call from the MCD, Delhi Municipal Corporation, calling that we are coming to your house for doing some fogging. I was shocked. What is happening? Then he said, your daughter has got dengue. But I already talked with the doctor. He said that nothing, that is just a false positive result. Okay, and there is nothing wrong with that one, and she has been treated with antibiotic and this thing, and is going to be discharged. I was pleasantly surprised and I was excited, and then I was sorry that why in TB that sort of a thing is not happening. because there is a laboratory detect a positive test. It is their public health responsibility to inform them, and it is their response of the public health system to respond to that particular situation. It doesn't matter who am I. They say that I am staying in whatever the posh colony, it doesn't matter for them. Yes, that need to be addressed as a public health problem. TB, unfortunately, we are not able to catalyze that. So there's a lot of such regulations, such actions are required, and that requires a lot of concerted effort from all of us. And I think that the solutions will come from those implementable solutions rather than, changing certain policies alone.
Kerry, going to give you the last word. I'm going to take Srinivas's words. It doesn't matter who I am. But doesn't it matter who I am in TB right now? Because it matters a great deal, right? Where I live, what I access, what I can access. And that situation is deeply linked to how empowered I am in that sense. And what Srinivas is really making a case for is it shouldn't be that case, but it is.
And I think that's really what a human rights approach has to offer. Because first of all, I just want to say there are many positive things that we have noted in our report about the DOT centers, but let's be honest, you all don't, not especially sexy to share the very nice things that we observe, but they're there in the report. There are good things happening. Second thing I just want to briefly say is that there are a lot of schemes already addressing nutrition for BPL people and for marginalized communities, and there needs to be more convergence among different schemes. Are people who are going to DOT centers, do they have a BPL card? Are they registered at the Anganwadi Center? Are they getting adequate, adolescent girls, pregnant women, lactating women, kids should all be getting supplemental nutrition from the Anganwadi? Is that sort of thing happening? Those schemes are there, and there needs to be more convergence between all of them. And the last thing, coming back to your question, yes, maybe the stories of our clients and maybe the stories in our report are stories, and maybe they are exceptions to the rule. But when you look at it from a human rights perspective, those aren't stories. They're fundamental rights violations, and they deserve attention, accountability, and justice. If there's a domestic violence case, even if 10 women have never experienced domestic violence, for the one woman, you don't say, that's a story, we're still doing a lot of success in combating this. No, you file the woman's case, you pursue justice, you get her accountability for whoever did the crime, and you provide her with support systems to continue her life. This is the same approach we need to take to each story where there's a denial of treatment, where there's death, where someone develops multi-drug resistant tuberculosis because of inadequate treatment before that. We need to view these stories as the fundamental rights violations that they are under Article 21 of the Constitution. That brings us back to the patient-centered treatment. It brings us back to the government obligation and accountability, and hopefully it brings us to a situation where tuberculosis becomes the exception to the norm of a healthy, happy citizenry.
We've gone way ahead of time, but I'm going to still open this to the audience because I think we have a very interesting panel, and I know there are lots of questions. I saw you first, Plessy, and so you can come in after that, but very briefly. And please say who you are and who you're directing the question to. That'll be helpful.
Blessy Kumar, Global Coalition of TB Activists, and I'm just responding to Dr. Sharma at the risk of getting a 0 from you. No, sir. No, I just wanted to say I agree with you when you say you can't compare two diseases. Maybe medically and scientifically, but I think there are lessons to be learned in terms of the community response that brought about the change, that brought about empowerment within the communities, that created demand for HIV. The campaign mode that polio went into. I think there are fantastic lessons in our country that we've, managed to achieve. So I think there's no harm in looking at that and learning and seeing how we can actually use that for TB, isn't it? I mean, I also agree with you. Disease, maybe you cannot compare, but the response, which has resulted in such tremendous results, I think we owe it as a TB community to learn from those good practices. And the second point is, that's not just to you. I think I've also faced it a lot. When sometimes you raise issues, the tendency in India is to actually shoot the
Messenger.
What's the word?
Messenger.
Yes, sorry, thanks. Shoot the messenger. And I think and I've been at the receiving end of that. I know Dr. Sachdeva is smiling and he agrees. But I think
Don't convey that. I didn't shoot it.
So much bonhomie. I can't get over this.
no. So I think what needs to happen, and I totally agree with what Dr. Sachdeva and Dr. Srinivas is saying. I think we need to be open and willing to dialogue. How can we? I'm not just criticizing the program. I criticize NGOs. You know that. I criticize WHO. I criticize Stop TB Partnership. I think as people, responsible citizens, if we see violation of any kind of, things that should be happening, I think we need to raise our voice. So for us, I think what's important is having a place at the table and being open to a dialogue, and we have achieved tremendously. I mean, where were we 6 years ago? That's how long, and I think I've been actively in this. I think we've come a long way. But I think to have that space, have an open mind, and actually accept, the first step is to say, yes, there is an issue. India is a huge country with a huge burden. We're not going to do, miracles or magic and overcome this overnight. But we all need to work together, and that's when it's going to happen. And I think that kind of openness needs to happen, and kind of respecting and valuing the different players, the stakeholders, is how we are actually going to go ahead with this.
I mean, I think it's an interesting point also, because to my mind, sometimes diseases are very comparable, because at the end of that line is a patient, and there is a system which is responding to that patient. The disease or the ailment shouldn't be that important. What should be important is the response. Yes, sir. Oh, okay.
Can say that indeed even Ebola can learn from HIV. The way people are dealing with Ebola shows how they were dealing with HIV before, and we already know from experience some things will not work. So that's the essence I wanted to make, but she's made it better than I could.
So, let's just take this question and then we can...
I'm Dr. Bhatta from the SARC TB HIV Center, Kathmandu. My question with Dr. WHO, Dr. Srinivas. One of the concern issue globally now, the raise to the WHO also, why still we are waiting for the MDR cases, especially for the Asian region, for the 18 to 24 months. We know the lot of evidence now we have in the Bangladesh regime, that's around the 10 months regime, and if still we are holding that things, maybe that concern for the 24 months to 18 months in the Asia. So any possibility for the drug regimes time, because now concern in the India, I know they already in Sri Lanka have the very good programs with the nutrition, and that's very high success rate in the Asia now in the tuberculosis program, and India is also adopting that model. But now the globally peoples are waiting. Why still we are waiting for the regime times for the 6 months till 24 months? Any hope?
This is a regime question to you, specifically.
Yeah, I would love to have a regimen with the 1 month, or if possible, even less than that. Saying that we do know that the 9 months regimen has shown a lot of promises. I can only tell you that this has been WHO, when they generate certain policies, it's not as quick as we really like to have. Okay, probably the only quick things which come up was on Gene Expert and later bedaquiline. Even I am surprised at the pace with which this came. However, all evidences are being for that, the 9 months regimen, and there is a committee who is reviewing that. Even recently there has been another review. ultimately we need to understand WHO as an organization does not make any policy. It is the technical committees which actually involves the people, and they give it to a review of literature. They come up with their available evidences. Then a lot of people groups sit together, and then they say that it has got no evidences, but we strongly recommend. And then you have gotten the guidelines, something like the strong recommendation, weak evidence, and then you say the conditional recommendation with a strong evidence. So it's a very interesting thing. It's going to happen. I also, just like you, I'm part of you rather than part of WHO. So I want something which to come much faster. I like to have its 9-month or 6 months regimen, but WHO takes its, that committees takes its due time.